was a re-recording of the July 31st Integrated Care at NeoMed, or ICANN ECHO program, the didactic blitz covering mental health disparities. I pulled heavily from this article noted on the slide, and in talking about mental health disparities, we're largely going to be making the case for why severe mental illness should be listed as a disparities category. Severe mental illness is defined by SAMHSA, the Substance Abuse and Mental Health Services Administration, as a diagnosable mental, behavioral, emotional disorder that causes serious functional impairment and substantially interferes with or limits one or more major life activities or one or more major life areas. The U.S. Department of Health and Human Services defines a health disparity category as a subpopulation with a particular type of health difference that's closely linked with social, economic, and/or environmental disadvantage. As you see from this quote, there's an acknowledgement that health disparities impact those with mental health conditions, and that really anyone who's experienced discrimination or exclusion, which we know persons with severe mental illness have. Yet the National Institute on Minority Health and Health Disparities and National Quality Strategy don't formally recognize people with severe mental illness as a disparities group. People with mental health conditions in general comprise a vulnerable population, and they meet the criteria for vulnerability as identified by an analysis completed by the World Health Organization. And we also know that other vulnerable groups have high rates of mental health conditions. The category of severe mental illness differs from traditional designations that are typically defined as, they're partially defined by a group. It's partially defined by a group of diagnoses rather than the more traditional demographic characteristics. And it does comprise a smaller portion of the world population, but listing it as an official designation category has many important implications, which we will get to in a little bit. People with mental illness are subjected to stigma and discrimination on a daily basis. Our actions, I believe, follow our beliefs. And if we view people with mental illness according to viewpoints from a stigma model and from a stigma lens, we're more inclined to exclude or avoid them, those people who have a mental health condition. We also tend, if we believe in myths, we tend to support solutions that are not actually going to provide a solution because they're based on the myth and not reality. People with mental health conditions face disproportionate barriers in attending school. They have high rates of physical and sexual victimization. They frequently encounter restrictions in their ability to exercise political and civil rights and their ability to participate in public affairs. The statistics on mental illness among people who are homeless continue to be staggering. The U.S. Department of Housing and Urban Development reported that in 2015, more than 500,000 people experienced homelessness, with nearly 175,000 of them unsheltered during the point-in-time count. Based on a brief survey, 60% of the unsheltered individuals reported to have a severe mental illness. A disproportionate percentage of population with severe mental illness lives unsheltered. While 30% of all homeless people are unsheltered, 43% of those with severe mental illness have no shelter. Criminalization is one of the hypotheses, and probably the first hypothesis that looks at why we see an overrepresentation of people with severe mental illness in the criminal justice system. The criminalization theory posits, or hypothesis posits, that the overrepresentation of people with mental illness in the system is the result of deinstitutionalization. So deinstitutionalizing psychiatric hospitals and the subsequent underfunding of community mental health treatment, along with tightening of involuntary commitment laws. There is a newer perspective with a growing body of research called the criminogenic risk perspective, which identifies a set of broader factors at play for people involved with the justice system, both those with and without mental illness. An increasing number of researchers and advocates point to poverty as a key driver of justice involvement for people both with and without severe mental illness. Many people with severe mental illness live in environments and communities where there's a high rate of crime and violence, ambient substance abuse, and social disorganization, all of which can increase the risk of justice involvement. Approximately 2 million times each year, people with severe mental illnesses are admitted to jails across the nation. Nearly 3/4 of them have a co-occurring substance use disorder. In 44 states, A jail or prison holds more mentally ill individuals than the largest remaining state psychiatric hospital. Individuals with psychiatric diseases like schizophrenia and bipolar disorder are 10 times more likely to be in jail or prison than a hospital bed. Hundreds of thousands of these men and women live really desperate lives. They're living on the streets, they're living in overflow emergency rooms, and so much in the system. Numbering somewhat fewer than 4 in every American adult, individuals with severe mental illness generate no less than 1 in 10 of the calls for police and occupy at least 1 in 5 of the America's prisons and jail beds. Beyond that, you can see that untreated severe mental illness, it actually increases the risk of being fatally shot by the police by 16%. Once incarcerated, individuals with severe mental illness have longer periods of incarceration. They're more likely to stay there for a longer time for even the same kinds of charges. They have more difficulties with the staff, the corrections officers, and with other inmates. They are overrepresented in solitary confinement, disproportionately victimized. They do have higher rates of physical violence towards other inmates. They have higher rates of suicide and higher rates of recidivism. Many go without psychiatric treatment at all while they're there. Others receive inadequate treatment with a lack of trained staff, underuse of evidence-based practices, and inadequate jail formularies. For this and all of the other healthcare connected reasons and the reasons why we try to practice integrated care, people with severe mental illness are much more likely to experience disability and die prematurely. A recent meta-analysis found that people with mental disorders have an all-cause mortality relative risk of 2.2 compared to the general population, with a median of 10 years of potential life loss. Furthermore, severe mental illness is associated with a lower quality of care and a higher cost of care. Much of this, and we've talked many times about the various reasons that there's a higher cost of care and lower quality, and obviously everyone watching this understands that because that's why we're taking part in the integrated care echo. But diagnostic overshadowing is also a really big piece of this. People with severe mental illness have poor access to health and social care, and worse healthcare outcomes. And part of this is due to what we see, the result of discrimination and stigma. So diagnostic overshadowing is a misinterpretation of physical symptoms as the symptoms of a mental illness. So if a person is known to have some type of an anxiety disorder and they show up in the emergency room maybe a couple times a year with something that looks like an anxiety disorder or panic attack, one of those times might be a heart attack that ends up getting missed because they're looked at and just assumed that it's because of their mental illness. There's a lot of very horrific case studies and personal reports throughout the literature on diagnostic overshadowing, just the real trauma that it causes individuals and their families. Other vulnerable groups also have high rates of mental health conditions. So looking at the situation from flip end, vulnerability actually can lead to poor mental health. Stigma and marginalization of other groups generates poor self-esteem, lower self-confidence, tends to reduce motivation, and causes a person to feel less hope for the future. Stigma and marginalization also result in isolation, which is an important risk factor for mental health conditions. Exposure to violence and abuse can cause serious mental health issues, not only depression, anxiety, but somatic complaints, substance use disorders. And mental health is impacted detrimentally when civil, cultural, economic, political, and social rights are infringed upon, or when people are excluded from income-generating opportunities or excluded from educational opportunities. So addressing mental health problems in vulnerable groups actually may facilitate the development of more positive and productive outcomes, and which would include things like improving economic participation, in social and civic activities. This diagram looks at the impact of neighborhood conditions on mental health. And in the face of harsh social issues and physical surroundings, people can become fearful. They may respond quite naturally from a defensive lens to protect themselves and their loved ones, all of which ties into and exacerbates mental health. We know that people who are poor, living in poverty or lower socioeconomic status, have limited access to care. And this is not just the most poor, this is even what would be considered the working poor, or an ALICE category. ALICE standing for Asset Limited Income Constrained and Employed. Sorry about that. Asset Limited Income Constrained and Employed. It took me a second to think of what the acronym was again. But they have less access to care. And even when the poor are given health insurance, they're 3 times more likely to be hospitalized for mental health services than non-poor. This is more than 3-fold variation in mental health hospitalization. It was not, in the studies that looked at this, was not driven by demographic or geographic characteristics. And it's an important findings just so that we can look at the implications for healthcare policies for the poor. But obviously further studies are needed to understand the extent to which the disproportionately high rate of mental health hospitalizations are driven by provider-induced needs, or what is really driving these kinds of statistics. Continuing to look at poverty, poverty really is a two-way cyclical relationship between mental health and socioeconomic status. Mental health issues can lead to a reduction in income, which interferes with employment, interferes with education, which can further reduce income and entrenching a person into poverty, which then increases stress and increases risk of and presentation of mental disorders and mental illness. So you can see how this just becomes a snake eating its tail. So knowing that other vulnerable groups have high rate of mental health conditions, it's important that we try to look at this from both lenses and try to address the mental health problems in vulnerable groups and also address the vulnerability of those with mental illness. So I thought this was kind of a neat graphic for the time to change, or hashtag in your corner. But the point of categorizing mental illness as a health disparity is that it would allow for inclusion in annual reports, and it would allow for more funding to advance the research on the population. A disparities designation puts pressure on organizations and agencies to develop quality measures that could be used in value-based payment models. It encourages them to incentivize the development and application of evidence-based practices to expand research and better understand the factors that result in unequal care. It could also allow for better comparison of performance on standard health measures when looking at the subpopulation of persons with mental illness compared to the rest of the population, allow for development of quality indicators. For example, the high rate of diabetes, hypertension, and hyperlipidemia among people with severe mental illness would be a quality indicator that we could look at. A composite indicator that measures medication adherence across the common comorbidities could capture important trends and help us to understand what's going into these health disparities. Labeling it as a health disparity category could aid in refining the research and technical assistance, and really just bring a lot much more attention to this by systems and organizations such as accountable care, which could allow for more incentivized integrated care and really being able to push our care to a much better practice and standardization, which would allow for some of these disparities to hopefully go away. So thank you. Here's the list of references, and reach out with any questions.